Thank you very much. I'm going to talk about eruptive calcified nodules. The first report actually was an IVUS report in 1996, published in the American Heart Journal. You can see in the angiogram a patient presenting with an acute coronary syndrome and a filling defect in the LAD, and we thought that this was a thrombus. We did everything possible to make the thrombus go away. It did not, and you see in the IVUS, an old IVUS, that 25 years ago, that this represents a calcified nodule. This is what they look like pathologically. They are clusters of small pieces of calcium mixed with fibrin as well as with lipid, and that's why you don't see penetration of the calcified nodule with OCT. The eruptive calcified nodules, and this represents a study from the City University of New York with micro-CT showing these little white dots are little bits of calcium that cluster to form a calcified nodule within the fibroatheroma. There are two types of calcified nodules: eruptive calcified nodules, in which the fibrous cap is disrupted, and these patients are old and present with non-STEMI, and non-eruptive nodular calcium, where the patients are younger, present with stable angina, and especially the fibrous cap is preserved. Here on the left is an eruptive calcified nodule. You see the little bits of calcium sticking into the lumen, and you see that there is no penetration by OCT because these calcified bits are embedded in fibrin. And on the right, you see an eruptive nodular calcium with an intact fibrous cap and no penetration of the bits of calcium into the lumen. OCT is the best way to differentiate the two. With IVUS, it is quite difficult. The only exception is if you have a patient population that is essentially an acute coronary syndrome population and you're studying the eruptive nodules or the nodules with IVUS, they're probably all eruptive. This is what they look like in progression. You see on the left, at the proximal right, which is the most common site of a eruptive calcified nodule, you see calcium shown by the little white stars. And at 9 months follow-up, there is significant angiographic progression, and you see disruption of the fibrous cap with protrusion of the calcium into the lumen. It's been looked at why, what tends to predict progression, and this is a study from Japan, and one of their interesting findings is that calcium with attenuation, again indicating lipid or fibrin, is one of the predictors of progression, along with the amount of calcium, the angle angiographically, the bend point in the vessel, the time since the last OCT, distal left main location, and especially patients who are on hemodialysis, and we'll come back to the hemodialysis issue in a second. Calcified nodules tend to occur more commonly at stent edges. This is a study that we just completed, and we saw that at the edges of previously placed stents, where the edge of the stent was in a calcified lesion, we have a 15-16% frequency of an eruptive calcified nodule at follow-up. Tactics was a Japanese study looking at causes of acute coronary syndrome and the long-term follow-up, comparing plaque rupture, plaque erosion, and calcified nodules. And look at the calcified nodule character. A column, these are older patients, less often male, presenting more with non-STEMI, and you can see especially over 20% were on hemodialysis. This summarizes many studies looking at the impact of hemodialysis, and you can see that if a patient is on dialysis and presents with an acute coronary syndrome, the prevalence of a calcified nodule can be as high as 60%. Even if you don't treat them, they do worse. This is from CLIMA study of Francesco Prati in Italy, And you can see that calcified nodules with disruption have a worse outcome compared to those without disruption. Again, two examples. The top example is an intact fibrous cap. The bottom example has disruption of the fibrous cap. And you see the event-free survival curves that calcified nodules with disruption treated medically have about a 25% event rate at 1 year follow-up. Many studies have compared erosion, ruptures, and calcified nodules. I'll go through them kind of quickly because they all show the same thing. Calcified nodules, as the cause of acute coronary syndrome, have the worst outcome, no matter how you treat them. So here you have one study from Japan. This is again another study from Japan where patients were treated with newer generation DES, and you can see the freedom from MACE at 6 years of follow-up is about only 50%. This is a study of calcified nodules treated with rotational atherectomy plus stenting, and you can see that the MACE event rate at several years after implantation is as high as 35%. And back to tactics that I mentioned previously, at 1 year follow-up, ACS caused by calcified nodule treated with stent implantation has a 32% event rate at 1 year of follow-up. We looked at eruptive and non-eruptive nodular calcium to try to understand a bit about why the eruptive ones do so badly. So we did baseline, pre and post PCI OCT. You can see on the left an eruptive calcified nodule, and after stent implantation, there's actually good stent expansion. It was 90%. That's because the little bits of calcium are distributed. While on the right, a non-eruptive nodular calcium, because of the nodule as well as calcium opposite the nodule, has a worse stent expansion. Nevertheless, when you compare the event rates, the event rate of an eruptive calcified nodule at 2 years of follow-up is twice that of non-eruptive nodular calcium. So this is the one situation in which bigger and better does not lead to a better long-term outcome. The better acute result in eruptive calcified nodules does not translate into better long-term outcome. In terms of predictors of events after stent implantation, this is another study from Japan, again showing that hemodialysis and what they call a dark calcified nodule, which is a calcified nodule embedded in fibrin or lipid, have the worst events at follow-up after stent implantation. Now, if you stent in a calcified nodule and the patient presents with restenosis, the question is why? And every single study shows that most of the time restenosis is caused by reintrusion of the calcified nodule into the stent. In this study, over 80% of in-stent restenosis were because of reappearance of the calcified nodule inside the stent, and in this study, it was about 60%. So what about in-stent restenosis and stent thrombosis? Well, we looked at proximal right coronary artery in-stent restenosis, and protruding calcified nodules are responsible for about 10% of in-stent restenosis in the proximal right, and they occur early. They occur within 1 year in a predictable fashion, while other causes of proximal right in-stent restenosis occur later, typically more than 18 months after stent implantation. The study from Japan did directional atherectomy of in-stent restenosis, and they showed that in dialysis patients, there was histologic evidence of a calcified nodule and that it occurs in the first year after implantation. So everything that we know about these eruptive calcified nodules is that they come back as reoccurrence of the calcified nodule inside the stent, and they're tough to treat. So ISR by calcium compared to no ISR calcium has a worse event rate, but it's almost entirely in the group with a calcified nodule inside the stent. Smooth calcium inside the stent as part of typical neoatherosclerosis or old neointima doesn't have this kind of problem. So in-stent restenosis with a calcified nodule treated has a worse outcome. And it really doesn't matter what you do. This compares drug-coated balloons and drug-eluting stents. They all do badly. There is no magic solution for this problem. This shows in-stent calcified nodule versus in-stent restenosis without a calcified nodule treated with drug-coated balloon, and the recurrence rate at 2 years is 85% in the drug-coated balloon group. The same thing, by the way, also holds with stent thrombosis. I'd like to finish with a case that illustrates this problem. 45-year-old male with class 2 angina, risk factors of diabetes, hypertension, and smoking, and he has chronic renal failure and is on hemodialysis. You can see the typical proximal right coronary location with what appears to be a filling defect, and by IVUS you see in the middle panel calcified nodule, probably an eruptive calcified nodule by its configuration, but as I mentioned, OCT is better for this. Was treated with standard PCI techniques with a stent and post-dilation with a 4 millimeter balloon at 24 atmospheres. The angiogram looks pretty good, but by IVUS, stent expansion is only about 45%. 2 months later, it's back. You can see it angiographically, and you can see that the IVUS picture is very similar to what it looked like the first time. So this time they used a drug-coated balloon, trying to find a different solution, a 3.5 drug-coated balloon at 20 atmospheres. The angiogram isn't quite as good as the first procedure, but the OCT actually looks reasonable. There's a lot of blood in it, but the stent expansion, or the old stent expansion, is reasonable. 2 months later, it looks identical, and then the angiogram is in fact worse, and by IVUS, the length of the eruptive calcified nodule is much longer. So another stent, this time a 3.5 Nobori at 16 atmospheres. Again, the angiogram looks pretty good. And the OCT, by all measures, looks great. Another 1 month later, it's back. So that is maybe an extreme example, but not an uncommon example of the problem of eruptive calcified nodules. There is no acute. The acute treatment is easy. The long-term treatment is not easy because we don't have a solution, and they keep coming back almost no matter what you do. So calcified nodulars, particularly eruptive calcified nodules, are becoming more common. We never used to talk about this, and now we talk about it every time. Half the cath conferences I attend, they present calcified nodules. They're becoming more common, I think, as our patient population ages, and more patients are being treated with long-term statins, which we know increase coronary calcium. While the acute results are good, the long-term results are poor, regardless of the devices used during PCI treatment. It doesn't matter what stent or even a non-stented strategy, these patients do poorly. Thank you for your attention.